Chapter 27, The Child with Cerebral Dysfunction, Part 1. This is just kind of a little review of the structures of the cranium, right? You've got your skin, then you've got your skull, the bone here. This is just the periosteum layer around the bone. Underneath that, you have the dura, and it's got a few layers, but we're going to just talk about things being epidural, so below the skull and above the dura, or subdural, below the dura, which puts them right against the cerebral tissue. So our big concern is increased intracranial pressure. Inside the skull, about 80% of the volume's brain, 10% cerebral spinal fluid, and 10% blood. If any one of those increases, you will get increased pressure, or it will decrease the others. There really isn't much ability to compensate. Babies who still have open sutures and that fontanelle have a little bit more ability to compensate, but it's really not much. So what causes a change in that? Well, things that cause extra brain tissue or volume are things like tumors. Things that cause extra CSF. We can either increase the amount of CSF that's being made or interfere with the normal flow of it so that we have more inside the brain, or we can have more blood from bleeding, or cerebral edema, where you've got tissue or serous fluid moving out into the tissue, making more volume there. So how do kids get increased ICP? Well, falls are a really common cause. So what are the signs and symptoms, the clinical manifestations of increased ICP? In an infant, it's going to be that fontanelle. It's going to be tense and bulging. We're going to see the sutures separated. Our book talks about McEwen sign, which says if you kind of knock on the head, it has a cracked pot sound. I would not recommend doing that. They're going to be very irritable. The parents will say they're really unconsolable. They have a high-pitched cry. You'll hear the nurses call this a neuro cry. It is not a normal baby cry. It's higher pitched than normal. They'll have increased head circumference and dilated scalp veins. They're not going to feed well. They're going to cry when they're disturbed, right? They have a headache. They don't feel good. And then setting sun eyes, which is that picture over there where the eyes are deviated downward, and you can see the white of the sclera. That's a fairly late sign. And the clinical manifestations in children: headache, nausea, vomiting, vision changes like double vision, diplopia, or blurred vision, seizures, drowsiness, decline in school performance if this is something that's happening slowly or is not at a dangerous level, decreased activity or motor performance. They may be wobbly, and then increased sleep and lethargy. So late signs are vital sign changes: bradycardia, decreased motor response to command. So this is when you ask for them to squeeze, they don't. Decreased sensory response to pain, changes in pupil size, right? That's when we check early, except it's actually a late sign when we see a change in pupil size and reactivity. That's bad. We're at late signs. There's changes in posturing, the flexion and extension posturing, changes in respiration like Kind-Stokes respirations, papilledema. This is swelling of the retina. It's a very reliable sign in children, but it's a late sign, and coma. Note that the earliest indicator is change in level of consciousness. So that's the one we need to be assessing to see if they're improving or deteriorating. And we assess that using the Glasgow Coma Scale, right? This is similar to with your adults. We have a little bit of a change for kids under 2 because they're not verbal. But otherwise, it's the same coma scale you're used to. We have eyes between 1 and 4, motor responses between 1 and 6, and then verbal between 1 and 5, so overall it adds up to between 3 and 15. We generally consider 8 kind of the really significant level of coma. Anything below 8 is a significant level of coma. Above that, we're certainly still watching them closely, but the outcomes are much better above 8. And here you can see we do have a different grading system we can give for nonverbal or infants. So how do our vital signs change with increased ICP? Well, you can get changes in temperature, and sometimes these are extreme. This is where you can get hyperthermia, where the person's 104, 105, 106, and they do not respond to antipyretics. With infants, they can often go hypothermic, and that's in an infection or anything else. So we need to, in infants, we're worried about elevated or subnormal temperatures. Pulse can be rapid, it can be slow but bounding, or it can be very feeble, which is just weak. And this is pressure on the vagus nerve in the brainstem. It can change in any way. Blood pressure also can be normal. Kids are really good at maintaining their blood pressure until they can't, and then it'll change real suddenly. Or it may go high or it may go low. If it's low, they're in shock. They are past the point of being able to compensate. This is an emergency. One thing you're likely to see is a widening pulse pressure. So the systolic pressure goes up while the diastolic goes down. This is the body's way of trying to get more blood and oxygen to the injured tissue without increasing a lot of volume of blood there, or without increasing the pressure a lot. So it goes both higher systolic and lower diastolic. That's a widening pulse pressure. Neither of those numbers need to be outside of normal for that to be a big concern. And then respirations. Again, it just depends. They can be slow, deep, irregular. They can be that deep, regular, that the Kind-Stokes. It just depends. We can put pressure on the respiratory centers and get changes in just about any direction. So the important thing to note is changes. The direction of the change is not that significant. If you have a child who's had a head trauma, or for some reason we're watching and worrying about increased intracranial pressure, and their vital signs change, that is significant and should be reported. It does not matter the direction they change in. So pupils, pinpoint pupils, often happen with poisoning with certain chemicals, opiates and barbiturates, or it can be brainstem dysfunction. Widely dilated pupils can happen after a seizure or eye trauma, and particularly seizure or trauma, it may just be one side. If they're dilated and non-reactive, that's a big concern. That's kind of indicative that the brainstem is about to herniate, which is the brainstem pushes down through the tentorium, that opening right at the base of the skull, where the spinal cord goes and all your spinal nerves and the blood supply to the brain comes through there. So if we push the brainstem down in there and pinch everything off, we now are getting no blood supply to the brain. So fixed dilated pupils greater than 5 minutes, we're probably talking about permanent neurologic damage, brainstem damage going on. Other things that can cause fixed pupils, well, brainstem, hypothermia, they can be fixed or very sluggish kind of reaction, anoxia, ischemia to the brain, right? So we're not getting blood supply to the brain, or we're have so little oxygen in it that we're not getting oxygen there. Poisoning with atropine substances can do it, or if somebody's had eye drops put in, right? So always consider that. Don't get excited about the eyes if they've just had an ophthalmologist look at them. So a nursing alert, a sudden appearance of a fixed and dilated pupil or both of them is usually going to be a neurosurgical emergency. This is probably a bleed in the brain, an epidural hematoma that needs to be surgically removed. And that pressure will increase as that blood trapped in there increases. And this can cause herniation and death if not treated promptly. So some of the tests that have to do with neurofunction, the doll's head test, this is turning the head quickly. The eyes should try and stay focused on something. So they should stay focused straight ahead, even though the head's turning side to side. If the eyes just stay in place where they are and move along with the head, so they're not focusing on anything, that is a bad sign. If you think of your expensive dolls where you move the doll and the eyes kind of change direction, that's what should happen. That's normal. And your cheap Barbie dolls where they're just painted on, no matter how you turn the head, the eyes stay exactly the same, that's not normal. That's bad. Moving the head quickly from side to side cannot be done if you have not ruled out a C-spine injury. The caloric test or oculovestibular response, this is putting ice water against the tympanic membrane, the eardrum. This is extremely painful. This is one of the things they do to check for brain death. So you take ice water and squirt it in against the tympanic membrane. The eyes should kind of twitch towards the side that's being stimulated. If you have no response, again, this is one of the things they're testing when they're testing for brain dead. So the pontine centers have been impaired. You would never do this on someone who's alert. This is said to be about the most painful thing you can do to a human being. Looking at the retina, so a fundoscopic exam, having edema back there is a really significant sign. It shows that you have increased intracranial pressure, but it takes 24 to 48 hours of that increased intracranial pressure before you'll see it. So you know it's been going on for at least that long. When you do this, you're also looking for hemorrhages or other problems with the eyes. Posturing. We used to call this decorticate, and I always think it's like your arms are making an O, or decerebrate. They're stretched out. We now prefer flexion and extension because that's easier to remember and descriptive of what you see. If you think about it, her arms are covering her vital organs. This is at least a little bit of protection. So this is a little higher neurologic function than this, where you're just stretching out and totally exposing your vital organs to potential injury. So this is only one step above no response to painful stimulation. Babinski's. In a head trauma, we're going to check Babinski response. Normal for an infant is you come up that side of the foot and across, and their toes will flare out. By the time you're walking, or about the time you start walking, and definitely by 18 months, it should do the opposite, right? If somebody does that to you or to me, it tickles, and we squeeze our toes down. So if you think it's about the time they start walking, around a year, that should switch, and you should no longer have that Babinski reflex. Someone who does with a head trauma, that is a bad sign. In infants, we can't do everything we can with adults, so we're looking at some of the infant reflexes. The Moro response, that startle response, the tonic neck. If you turn their head one way, their hand that they're looking towards should go up and the other hand down. And if you turn the head the other way, their hands should switch. They should have those. If they don't, that's a bad neurologic sign. They should withdraw from pain. And that one's not just an infant reflex. We all should have that reflex of withdrawal from pain, right? So if those are not there in an infant, we're highly concerned of brainstem involvement or dysfunction.